This is the second part of our lesson Public Health Surveillance 2. This presentation was developed by Mark Durand, Narendra Singh, Tom K. Drzezinski and Hazel Clothier. Slide 18. What makes a good public health surveillance system? Slide 19. We begin with key concepts. The purpose of communicable diseases surveillance systems is to generate alerts. The purpose of NCD monitoring and surveillance systems is to show trends, and impact of interventions on those trends. Slide 20. We will now explore features of strong surveillance systems and look at common pitfalls. Good quality surveillance systems have clear objectives, conditions under surveillance, population of interest, who does what how often, and link to action. Slide 21. Good quality implicates that surveillance system is simple, flexible, valid, acceptable, representative, and affordable. A simple surveillance system is easy to get the data, easy to coordinate among players. A valid surveillance system has good data definitions. An acceptable surveillance system provides good feedback to stakeholders, for needed reporting. A representative system gives accurate picture of health situation with regard to time, place, and person. Slide 22. Who are stakeholders for public health surveillance systems? Data collectors. People involved in data transfer. Data collators and analyzers. Local, national, regional, and international decision makers. Funding agency that supports surveillance or intervention. Researchers. Anyone else who may be remotely interested. Slide 23. We have to identify some realities of current communicable diseases surveillance systems in the Pacific. Each country has a list of notifiable diseases. Notifiable diseases lists include epidemic and routine conditions. Reporting is by everyone, all the time. Summary reports are submitted monthly or weekly. Urgent notifiable diseases have been reported by fastest means. Syndromic surveillance put in place in recent years. Laboratories are often left out. Much effort, but often little action. It used to be the case that reporting was ideologic. Now we have a pretty good syndromic surveillance system for communicable diseases in place, thanks to PPHSN. Slide 24. When we analyze some realities of current communicable disease systems, we find they have an overemphasis on data collection. It produces high burden because even on the front lines, it includes many reportable conditions. Reporting often delayed or incomplete. System is very slow. Much effort, but often little action. Slide 25. If we look some realities of current non-communicable diseases system, we would find, uncoordinated on funding agency side. There are miscellaneous surveys not comparable to one another. Expanded idea that NCD surveillance is equal to NCD steps, or BRFSS. There are uncoordination among public health programs on country side by lack of agreed-upon country NCD programs and surveillance systems. Analysis and reporting have often been delayed. There were weak link to policymakers in action. Slide 26. Which are common surveillance system mistakes? Slide 27. The surveillance system for communicable diseases don't have handoff of responsibility. Gaps in surveillance are blind spots where outbreaks are not detected early and can get out of control. There was not 24/7 point of contact with communicable surveillance and response team. Slide 28. What's wrong with this syndromic surveillance report? No specified alert thresholds. You need these to trigger action. Slide 29. If you set alert thresholds, you can take decisions. PHSN established as threshold for action. Keep in mind that 90% of historical weekly counts are below threshold. Slide 30. Does this one look okay? Are you ready to send this out to your distribution list? Anything else you need to do now? Slide 31. Very common mistake. In case above, even 2 cases of acute fever and rash should initiate action, because this is your threshold for action. Often we see lab tests sent off island and further action wait until results come back. This is a mistake because we will see next two slides. Slide 32. The usual sequence of events is primary case. First case at district health center. Report to province. Samples taken. Lab results. Response begins. The opportunity for control and prevention of cases is limited. Delayed response means reduced impact of control and prevention measures, a little too little, a little too late. Slide 33. The ideal sequence of events must be primary case. First case at district health center. Report to province. Samples taken. Lab results. Response begins. It allows that potential cases be prevented. Slide 34. The most common mistake for NCDs is to estimate population prevalence of NCD risks and diseases based on clinical records and other convenience surveys. What is the problem with using these sources? First, they undercount the true number of cases in the population for most conditions. There is one exception: conditions like amputations that almost always occur or are recorded in the health system. Second, clinic attendees and convenience survey participants are not representative of the whole population. What are NCD Health Services data from registries good for? So, if clinic-derived data is not good for estimating risk and disease prevalence, what is it good for? What registries can these data be found in? Vaccination rates in immunization registries like WebIS, percent of patients screened for tobacco, HTN and DDM control and paper charts or EHR, if these have been designed to capture this information. Examples of indicators obtained from clinic data: HPV vaccine coverage rate of young women, percent of primary care clinic teens and adults screened for tobacco use and counseled if positive, percent of patients with hypertension who have BP under control, percent of patients with diabetes with blood sugar, A1C test, under control. They are showing how well NCD-related health services are being delivered to patients, compared with official guidelines. How well NCD patients' diseases are being controlled. Registries are also good for generating case management lists to guide outreach, that is identifying patients who are due for interventions. Slide 35. You can look other mistake: there are not surveillance plan or consistent collection of defined indicators. In our region, 83 don't have enough data. If there are not consistency over time, we cannot see trends. Slide 36. Now you are sending out your report. What is wrong with how you are doing this? Slide 37. You must share with all stakeholders. Note that feedback to reporting and clinics is especially important to keep them engaged. Slide 38. A common mistake for non-communicable and communicable diseases surveillance system is letting system get stale. You should be sure your communicable diseases surveillance's standard operating procedures and NCD monitoring and surveillance plan have provisions for updating membership of surveillance team once a year, with in-service training. It includes to review and update of standard operating procedures and monitoring and surveillance plans once a year.